Hello, on behalf of my friend and colleague Guy Bouguet and I, welcome to this special session on COVID. The COVID-19 pandemic has resulted in previously unprecedented challenges to transplant programs and physicians performing stem cell transplantation or delivering CAR-T therapy. This impact has extended beyond patient care to include logistics, administration, and distribution of our increasingly limited healthcare resources. The COVID pandemic is being a global event for which clinicians, nurses, and also patients have limited time to prepare before changing the way we navigate care. Speakers today are experts from different geographical regions and backgrounds, and they are going to share their first-hand experiences with us and provide recommendations on different aspects from standard care to vaccination. The purpose of this session is to raise where you, patients, family members, and donors are filling the gaps. So please write your questions using the question and answer tool in the platform. This session is for you. So to start, we would like to hear the headlines of each of our speakers' experience. We will give you 2-3 minutes to provide us with the headlines of your life experiential challenges. So please, Guy, could you introduce our first speaker?
Natacha, good morning, everyone. It is my pleasure to introduce our first speaker, Dr. Rafael de la Camara. Rafael is a clinical hematologist at the hematology department of the Hospital La Princesa in Madrid, Spain. He has been involved in hematopoietic stem cell transplant activity over the last 30 years. His main areas of interest is research and infectious complication of stem cell transplantation with patients, particularly with viral infections. Since May 2020, he has the pleasure to be the chair of the Infectious Disease Working Party at EBMT. Rafael, the floor is yours.
Thank you for your kind introduction, and I'm happy to be here in this session. Yes, my city, Madrid, was a hot spot of the COVID pandemic. We have until now more than 80 patients, hematologic and transplant patients. We have 21 transplant patients. In the first wave, we have 46, and the second wave, 36, more or less the same. At the peak of the first wave, was at the end of the March. At the hospital, we have 600 patients at the hospital. You have to remember that my hospital have 350 to 400 beds and 47 patients at the intensive unit care when we usually have only 20 beds. In the hematology department, we have to lock down the transplant program for 2 months. And really the first wave was like a tsunami for the staff and for the patients. We have a dramatic shortage of personal protective equipment, which resulted in a very high rate of infection. To get an idea, nearly 30% of all the healthcare workers in the hospital were infected. We have 3,000 health workers. And at the hematology department, 50% of the nurses were infected. So that was a really terrible situation. And this has an impact, of course, in the transplant activity. We compared to the 2019, we have 30 less transplants done in 2020. So our experience was really terrible in the first wave, and the second and the third wave is nothing to do with that. Now we have a lot of things put in place to decrease the impact, and now the situation is controlled. But the first wave was a tsunami. We really can handle this in a good way, and the patients suffer and the health workers suffer a lot. So that was my personal experience in this place in Madrid. Thank you.
Turn goes now to Denis Garcia. He is nurse working at specialized in oncology and hematology in Hospital Clinic of Barcelona. He is part of the multidisciplinary bone marrow transplant team and caring for this population at home. Please, Denis, could you share with us your headlines?
Good morning, everyone. This is Denis. It's my pleasure to be here sharing my experience with you. So I work in the hospital of Barcelona. So during the pandemic of COVID, when the global spread of COVID were very quickly, so we were forced to change our system of our health system and implemented a new restrictions all over to contain the virus. So we decided to open a brand new hospitalization ward which only treat hematological patients with suspect or diagnostic COVID. And then with that, we can continue to provide especially cancer care, such like stem cell transplantation and palliative care. So in this new ward, we implemented general restrictions like seal up the hematologic ward. We limited the visits strictly, and we must wear a day-long surgical mask. So to contain the virus, we separate the clean areas from the dirty areas. So it was unexpected to have a new hematological ward only for this patient, because we did a small comparison from last year. So about the stem cell transplantation, 12 were performed in our hospital. So the overall number of transplantation in 2020, there were just 7% less than last year. And about the data of CAR-T, we performed one more CAR-T infusion than last year. So I think it is very important to have a specific hematologic ward to contain our special patient, that we can decrease the exposure of our staff, and it will be good for our patient. Thank you very much.
Very much, Denis. Now it is my great pleasure to introduce a friend of mine, Maja Kocić. She is the president of the Serbian association LIPA. She's the president, yes. Maja, a patient, in 2003 was diagnosed with DLBCL, a form of lymphoma. After several treatments, Maja received a stem cell transplant in 2004. Maja has been an active patient advocate for more than 12 years now, working on a regular basis on raising the level of knowledge about lymphoma, giving information and supporting patients, advocating to the rights of a lymphoma patient, providing a better access to new treatment and clinical trials, promoting a healthy way of living, and sharing the inspirational story of a survivorship. Maja, the floor is yours.
Thank you, Guy. Thank you for kind introduction. Hello, everybody. First of all, I would like to thank the organizers for inviting me and giving me the opportunity to be the part of this session. As Guy said, I had stem cell transplant. I was diagnosed with the diffuse large B-cell lymphoma, the 4th clinical stage, in 2004. But as a consequence of all treatment I received, in 2009, I was diagnosed with secondary hypogammaglobulinemia, which means I'm very prone to different kinds of infections because of weak immune system. But regardless of all health issues, I was and I'm still pretty much living a normal life, working a lot, as Guy said, being active, being involved in many different projects dedicated to lymphoma and CLL patients in Serbia, with the main goal improve their lives and to help them. It has been very much needed, especially during this pandemic. And our patients at the beginning of this pandemic were desperately seeking information and help. So as patient organization, we needed to change the way we used to see and do things. We needed to be very quick in response and reaction. We needed to turn to some other solutions and digital technologies more than ever before. Of course, this pandemic has brought a lot of challenges to all of us, especially to patients and to patient organizations. And we faced, especially at the beginning of this pandemic, the lack of knowledge, the lack of skills, the lack of resources, the lack of confidence, the lack of information, reliable and complete information. But now it seems to me we have settled in with this new normality. I would like to add something. Actually, unfortunately for me, I have met this pandemic, the COVID-19, not only from a patient, hematologic patient and patient advocate perspective, but also from another angle. I contracted the COVID-19 last summer on July, and I must say that it was one of the worst periods in my life, with a lot of complications. And fortunately for me, now I'm very well. Thank you.
Thank you very much, Maja. We will jump now into the questions, and I would like to start with a question to Dr. Rafael de la Cámara. Considering the coronavirus outbreak, we would like to know which transplant and hematologic patients in general, including those who have gone or need to go under CAR T therapy, are most at risk and why?
Thank you. Good question. For transplant patients, the two most important factors that impact in the outcome are the increased age and poor performance status. There is a continuous effect, so it's not any cutoff that we can say that below or up that cut you are safe or you are in very much danger. But if we have to put a cutoff, for example, for age, it will be 50 years. So to be 50 years or older, you have increased risk if you are 30 years. And that is what we find analyzing a lot of hundreds of patients with transplant and COVID. And these two factors was the most important. It's not different if you are an autologous or an allogeneic, if you are with immunosuppression for GVHD. So these two factors the most powerful have an impact on poor outcome. Also, early after the transplant seems to be worse, particularly those patients who are below the 100 days after transplant, and even those who are below 1 year. So these patients with early transplant also seems to have a worse outcome. For oncohematology patients, the age is the most powerful factor for a poor outcome. Also, those who have other comorbidities, for example, hypertension or obesity, some diseases are with higher risk than others. For example, acute myeloid leukemia patients have higher risk than chronic myeloid leukemia patients. And some therapies seems to increase the risk. For example, monoclonal antibodies that are quite frequently used in lymphoma patients, and those also who receive conventional and intensive chemotherapy are also at increased risk of complications. So these are the most important risk factors for poor outcome in transplant and oncohematology patients. Thank you.
Doctor, there is another question for you. It is regarding the patients that already received a transplantation and are taking medication for graft versus host disease, for instance. Are those patients more at risk of developing a severe reaction to COVID?
This is also interesting. As I said before, to be on immunosuppression is not a predictive factor for a poor outcome, understanding for that death. So that is not the case. But it's true, the patients who are with immunosuppression have a higher probability to progress to lower respiratory tract infection. So although the outcome at the end, if you analyze a big number of patients, seems not to impact life or death, it impacts the progression from upper to lower tract infection. So also, you know that the COVID damage is not by the virus itself, it's by the immunological response. So the transplant patients have a very delicate balance between what will be a risk for increase in viral replication, and also the immunosuppression can in some way protect the patient from damage. So they have these two things. So at the end, the immunosuppression is not as worse as we think at the beginning of the pandemic. So if you have to receive immunosuppression, that is good. It is not a very very bad thing for your evolution. You have to keep care, avoiding the infection. That is important for every patient.
Doctor, I have a question for Denis. It's about his experience in the ward. Have you seen more patients, or have you seen any patients that were grafted patients that were with COVID, and how was their journey within your ward, if any?
Yes, actually, yes, I did met some patient, with that effect. It was very difficult for them because the first of all, they think about the death and the fear with the situation. And normally about the data that I have in our hospital, the 50% of those patients normally die. So it's sadly, I have to say that.
I would like to ask to Maja. You explained to us that you have lived the three different experiences. I mean, as a lymphoma patient, as a patient advocate, and also as a patient who have contracted the COVID. So could you please tell us how this experience have changed the way you are equipped to support the patients during the pandemic? What have been the most demanded services from the patients?
During the pandemic, it's true that we kept the normally activity of nursing. We stepped out the hematologic ward, and it was very difficult for us because we have been empowering patients about taking the self-care, and the caregiver, for example, is very important for us, but we limited the visit. So the familiar or the caregiver only could come over to visit them once per day. So it was very difficult for the communication, and the inpatients in our hospital, they need more care than the other ones, because the hematological patient, they need special care, and we need a special team trained as well.
Thank you, Denis. Maja, can you comment on Natacha's question?
I can comment this. The challenges for patients with lymphoma, CLL, and hematological malignancies, even in normal world, are numerous. And you can imagine situation now when you're being called one of the most vulnerable group of patients at greater risk of the COVID-19 with the increased mortality rate. It just added another layer of fear, of anxiety and uncertainty to our patients and to our family members. For me personally, because I said that unfortunately I met the COVID from different angle, and for our patients, the most important service we deliver to them as patient organization, there is no doubt this is the telemedicine, actually the platform for telemedicine. I'm so proud of that because my association initiated it and in close collaboration with some young IT company from the city where I live, we created this platform. And this platform actually is dedicated to patients with lymphoma and CLL. They can have 30 minutes one-to-one with one of 7 hematologists, because 7 hematologists took part in this project. Why? Because this is especially valuable and helpful for patients who are in long-lasting remissions, having their follow-ups delayed or postponed at that moment. It appears, this service appears, beneficial for both sides, for patients, for clinicians, because it keeps patients engaged, it keeps both patient and the clinical community on the right track.
Thank you very much, Maja. Now, I think it's time now to talk about vaccine. And this is probably the first question for Dr. Della Camara. Will it be safe for a transplant patient to receive, to get vaccinated for COVID-19, and which vaccine should be used for a transplant patient?
Thank you for the question. It's very important. The answer is yes, without any doubt. So the transplant patients and the oncohematology patients should be vaccinated. And in the majority of the countries, this population are prioritized against the rest of the population. So the authorities have understanding that these patients are at very high risk of bad evolution. And one of the most important measures we can do to prevent the bad evolution is preventing with a vaccination. So please, this is an important idea. If you are offered to take the vaccine, take it as early as you can. All the 4 vaccines that we have licensed in Europe, if we can have the slide, please, as you can see here, are safe for the patients. You can use any of those. You can't select or choose which one you would like to have. That is depend on the local policy of your country or in your area. You can select or choose between any of those, but you should be sure that any of those is safe for any of you. So it's not a problem of safety. So you can take any one of those: Pfizer, Moderna, Oxford, or Janssen. This is the 4 licensed vaccines that are in Europe. Other countries, maybe you have another vaccines. And the only problem is that you can't receive live attenuated vaccines and vaccines that contain replicating viral vectors. Those vaccines are very rare. None are in Europe, but maybe in other parts of the world you can have one of these vaccines. And this type of vaccines should not be used in transplant patients or oncohematology patients. But I repeat that the vaccines licensed in Europe, these 4 vaccines that you can see on the slide, are safe and can be used in any transplant oncohematology patients. Thank you.
Oh, yes, Maja, I'm just curious about how it feels for you, the vaccination challenges, how you have lived this in Serbia.
Well, I must say that in Serbia, the process of vaccination is very well organized. But what I'm concerned about at the moment, many people refuse to be vaccinated. Why? to my mind, for two reasons. Actually, we have Serbia offers our patients and our citizens the choice of 4 different vaccines. Some of them have authorization, European authorization. Some of them no. For example, Russian and Chinese vaccine. There is a lot of misinformation about vaccines, about safety, about efficacy, as doctor said, going around. This is the first reason. And the second reason, the process of authorization in Serbia for example, Chinese and Russian vaccine was a little bit faster than people expected. All of this actually makes our people and our patients a little bit mixed up and confused and suspicious. When it comes to hematological patients, I would say that our hematological society came up with recommendation on vaccination for these patients, and as doctor said, our hematologists usually recommend Pfizer vaccine for patients with stem cell transplant or some hematological malignancies.
Thank you very much, Maja. The question I have next is about differences between allogeneic and autologous transplant. Should the vaccine strategy be different between those two types of transplant patients?
Thank you for the question. No, the answer is no. Both autologous and allogeneic have to be accepted the same point of view of risk. Auto and allogenic patients have a higher risk than the population and have a very high rate of complications. So any autologous or any allogenic with the 2 risk factors I said before, the age and the performance status, should be vaccinated. So it's not distinguished between auto and allo. And this is quite similar to what we do with the regular vaccination for the transplant patients, for flu, for tetanus, diphtheria, polio, and other pneumococcus vaccines. We use usually the same vaccination program after the transplant for auto and allo. So the message is we will need to vaccinate autologous and allogenic in the same way.
My next question would go to Denis. Denis, from the nurse's perspective, how your practice has been changed given the pandemic challenges? I mean, from the support and communication to patients, what they need right now from you?
So actually, the patient just need that you stay with them a little bit more longer time. But sometimes during our practice, we just cannot do that because we have a lot of patients to attend. So, and also there is a team of psychological support for them, for the patient, and also for the familiars or the caregivers as well. But I found out that the patient, they are more time, they feel very, very alone during the hospitalization.
Thank you, Denis. A question, it's regarding the, I would say the local message that people or patients receive in different countries. It seems like in countries the message can be very confusing regarding which vaccine to use. There are, you mentioned, Dr. De La Camara, you mentioned those 4 vaccines that have received their authorization from the EMA. But as Maja talked about it, there are other vaccines that are coming into the European continent without authorization from the EMA, like the Chinese and Russian vaccines. But in general, a transplant patient, if given the choice, which vaccine should he receive? The AstraZeneca or Janssen vaccine, or should he receive the Moderna or Pfizer vaccine?
Very good question, but very tricky question, of course. The first thing is that there is not issue of safety. That should be clear. You can receive any of those that are licensed in Europe. Also, the Russian vaccine, Sputnik, is a fantastic vaccine. We have less information about the Chinese vaccine, but as I said before, if it is not attenuated vaccines, a live virus attenuated, or with a replicating vector vaccine, you can receive any of the vaccines that we have in the market. So no problem with the Sputnik, and with all the other vaccines that have no live virus or replicating vectorized vaccines. If you can choose, that is the problem. Of course, we know that in probably in the transplant patients and oncomatology patients, the vaccines as the other vaccines like flu, pneumococcus, and other vaccines will have a lower rate of response compared to the general population. So with that reason, if you can choose, we can select those vaccines that have demonstrated in a randomized trial to have the highest efficacy. And that will be the vaccine that have more than 85% prevention to COVID. We have several vaccines like that. For example, Pfizer, Moderna, Sputnik, Novavax have more than 85% efficacy in the prevention of COVID. So any of those will be excellent. There are others that have less than 85, like AstraZeneca and Johnson & Johnson, but that is not a problem of safety, I repeat. It's only a theoretical risk of efficacy. So in some countries, for example, these vaccines with a lower rate of efficacy are given to young population and not for immunocompromised patients, but that can be different from country to country. So you may wish to have a vaccine with a higher rate of efficacy, but in any case will be a problem of safety. You have to understand this, and please don't reject the vaccination because you think that the X or E vaccine is worse than other. So the important thing is to get the vaccine as early as you can.
Thank you, Rafael. Now, in less than 1 minute, I will ask each of you to send a message to the audience. Please, Maja, starting with you.
Thank you, Natacha. As a patient advocate, I can say that nobody knows what the future holds, and hopefully this pandemic will end soon. But I'm afraid of that. Maybe after this pandemic, another pandemic is coming. Pandemic of undiagnosed and untreated or improperly untreated patients. So we need to be ready for this, let's say, new pandemic. But I would like to point out that at least one good thing has emerged from all this situation, and this pandemic made us to think of collaborating and partnering rather than competing. And the collaboration is key if we want to win. Collaboration is key if we want to go on.
One minute.
For me, for example. Okay, so I think the most important message for the patient is they should avoid infection, because the consequence of infection in transplant patients is very bad. So you have to observe a social distancing, hand in hand, and the use of face mask. And also, as Maja have talked about, the telemedicine visits to decrease the face-to-face visits in the hospital are very important. And one important thing is the household contacts have to collaborate in this. that is quite difficult if you have teenagers. I know. But if you are taking a lot of precautions and you're 15 years old boy, is going out and get infected, probably you are going to get infected. So you should avoid the infection. Another important thing that you can do is vaccinate. Please don't reject the vaccine because you think it's less effective than others that you have read. Any of those that can offer to you are good and safe. So please get the vaccination. That's all. Thank you.
Thank you, Raphael. We're gonna have to conclude because we passed our time. I would like to thank you again, Maja, Raphael, and Denis for sharing your experience and your time. It is the key message here is please get vaccinated. We must be vaccinated as transplant patients. Ask your hematologist for which vaccine you can get and where to get it. But in the meantime, and even after vaccination, please continue to respect social distancing and have the safe behavior in order to be safe. Thank you again for listening, and we will probably talk to you very soon. Enjoy your lunch.